Hello, and welcome to Caring Conversations, episode 6. Liz, 6 episodes down. How incredible is that?
Who knew it? Who knew? I know.
Yeah.
We survived it. We're just getting the steam going, I guess.
Yeah. And I like to say that we are getting better at this. Who knew?
I like to say it too, whether it's true or not. You need the job.
So contrary to the fun that we're having today is a very big topic. It's a sensitive topic. So trigger warnings, perhaps. We are talking about palliative care. Lots of misnomers, lots of misconceptions, lots of unknown when it comes to palliative care. So I'm really excited to chat about this and hopefully demystify it all and share some of our phenomenal experiences when it comes to palliative care. In hopes that everyone can have a really wonderful, peaceful, comfortable dying process. I think that's the end goal for everybody. And, today we want to talk about it. It's a tough topic, so, listeners be aware, but it's a really important one. Sometimes they're hard conversations, and sometimes they're conversations that people just don't want to have. So for us to put it out there in the universe and just openly talk about it, share some of our experiences. My hope is that, between these conversations with you and I, someone will hear it and it'll make a difference, or it'll give them the power to then reach out and ask a question or talk to their loved ones about it. So I just wanted to mention that and chat about that quickly.
Healthcare and the palliative process and dying process, accessing long-term care, all of these conversations that we're talking about, you don't go to school and get a degree in how to manage my mother's dying process. Like, these are not educational opportunities that exist in the world unless you are dropped in, to the neck at a moment's notice, and it can happen. So I know that nobody here wants to have this conversation other than you and I, clearly. But it's a conversation that people need to have access to. Like you say, imposter syndrome, people might not be listening, but when they need us, to have that information out there is really a good thing. So should we dive in? What is palliative care? So what is it? What is it?
Wow, it's so big. I mean, it's essentially the process of dying and how we care for someone who has made the decision, or maybe subconsciously has made the decision that they would no longer like to pursue curative measures for their disease process, and would like to pursue comfort measures and make comfort a priority. I think palliative care is so broad in the fact that you can talk about palliative care at any stage in the disease trajectory, from the initial diagnosis where the prognosis may be 20 years. Or a diagnosis where the prognosis is very short and very life-limiting. So, in that sense, I think it's quite broad because it can take a whole different look and a different perspective depending on where we're at in that process, in end-of-life care and the palliative care process.
It's that shifting ideas of, is this a condition that we're treating, or can we prolong life? And then when that decision is made to say, you know what, I don't want to fight anymore, or it's not my quality of life is not such that I want to continue this road anymore. And you switch to comfort measures. So you're, instead of looking at how can we assist with making, helping with longevity of other organs and that sort of thing, we're now focusing strictly on comfort and, controlling symptoms of whatever the condition is that this person is existing with. So making sure that we're treating the human being, the symptoms, but we're not going to move forward with, controlling blood pressure necessarily. A lot of the times you have a laundry list of medications that you're on. And when you make that decision, you cut out a lot of medications and you just focus on what's necessity. So like you say, palliative care it can be a conversation that you start at the beginning of your process when this is a condition that is life-limiting. What do I want the end of my life to look like? And having those conversations, again, we always talk about this, but tell your family what you want in that process. So palliative care versus hospice care, what are your thoughts on that? Because I know it can be used interchangeably. Absolutely, it can. And I know different places it is used completely interchangeably.
Uh-huh.
What
Yeah,
are,
and I
what are
think
your
in
thoughts
order to
on it?
qualify for hospice care, you must have a palliative diagnosis and be within, in Alberta, and I think in most hospice situations, it is a 3-month um, timeline where we're anticipating that end of life will be within those 3 months. So, hospice care is very much taking that palliative approach of very comfort measures, creating a space where your loved ones can visit kind of at all times of day. It's very calm. It's very peaceful. Um, it's not the hustle and bustle typically that you see in acute care or other like long-term care units. Hospice care it's a very beautiful place. Like you can feel the energy is very calming. The people that work there are very calm, compassionate, understand the dying process and the end of life process very well. The physicians that are there are amazing people who also very much understand that process. And hospice care often brings in the maid situation, which is a hot topic, across all legislations these days, but medical assistance in dying. And so you can receive the maid procurement through hospice as well, or in your home. But we could talk
Yeah.
about that
Yeah.
later.
And I know there's like the hospice society as well. When you're talking about hospice society, they're non-medical. So you go, that's where the name I think gets kind of confused, is hospice care is bedside companionship operated with volunteers. And it depends on what area that you live in as to the functionality of whether they can actually come and do bedside care. I've been in really remote living situations where there was one woman that was hospice, and so you would phone her and she would say, yes, I have availability. And she would come and sit at the bedside as much as she could so that that person would not die alone. She did not do any of the medical side of it, but yes, she was there for that spiritual, emotional support. She was an ex-nurse because we're all deranged and really can't give it up. Once you care, you can't stop. It's really a medical condition for us. So if there's any cure for that, just let me know, holler. Please tag us if you have anything. But yeah, it's the hospice care, like you say, it isn't just about the hustle and bustle and getting you up and getting you going. It's you can sleep when you want to sleep. You can have loved ones there with you around the clock. There's no visiting hour restrictions. There's usually some pretty decent snacks kicking around if you're going that route. Yeah, so knowing that if somebody that you love, they make a decision where they want to pass. So hopefully, if you've had that conversation, they want to pass at home, they can still have that palliative team look after them at the home, or you can move into that hospice care in a facility that is 24-hour nursing care that has that sort of gentle touch that isn't, trying to get them up. They're just nourishing their soul, and their body as much as they're able to, and supporting the family. And like you say, the staff that work there are cut from a different cloth. The feeling, like you said, that energy when you walk into a hospice wing or facility, it's just down to earth. I don't know what kind of crystals and voodoo magic there is going on around there, but it is such a beautiful place. Like the experience is a beautiful thing. Yeah.
And I mean, hospice can be pediatric hospice, which I spent some really incredible time at a pediatric hospice in my early years of nursing, right through to, seniors. And they're, I think the way that we treat, and it's not treating, that's a terrible word for this. I think the way that we work together with families and patients that are, going through that palliative process is very similar across all age groups, where we are, nurturing and really spending some quality time and allowing families to spend quality time with their loved ones, taking away that care burden and just, making the environment really conducive to quality, loving time.
Yeah. It is. It's the highest quality care you can get in the healthcare field. Honestly, you can go to an ICU where you have one-on-one nursing care, but if you're looking for an actual quality, beautiful moment, it is always on that palliative care wing. Yeah. So, I mean, when you're talking about palliative care in your experience, where have you practiced in the home? Have you practiced in acute care? Like, what does that look like for you? What's the
Oh, yeah. I
difference?
mean, I've had the privilege of working in many different environments where palliative care was part of our job description, I suppose, which is terrible because it's a privilege to be a part of it. But from, like I said, pediatric hospice I've worked in. I worked in trauma for many years, and even in trauma where, typically we're very much in a life-saving, like everything we need to
Yeah.
save. And, families are faced with such a crisis. There is that aspect of palliative care where, you kind of shift gears and you go back and you talk, bigger picture. What is this going to look like long-term for you? And some of the most difficult conversations that I have had and been a part of are with families through that trauma experience, and where their loved one has, had some sort of trauma and they're now facing, a very life-limiting trajectory, and palliative care has become a process. But some of the most beautiful conversations too, it seems like when palliative care gets involved, we start looking at the patient as a whole again. It's not systemic where it's like, respiratory or GI or neuro or anything like that. Like palliative team, when they come in, they tend to really get everybody working in the same direction and start thinking as holistically as possible about what is best for this patient. And that's a pretty incredible approach. I love when I get to work with the palliative care team because they're a phenomenal group of people.
Yeah, they are. Yeah. And it is that holistic approach. You go in and it's more about what was the treat that they really loved and how do we get it here?
Yes.
Yeah. And is there a dog? Let's get that dog in
Yeah.
here. And did they
Yeah.
love music? Do they want some music playing in the background to help ease them? Because, they can still hear. We always hear that, the last sense to go is hearing. So always talk to these people that are going through the process of dying. And if they can't respond, they can still hear you. So that's what we always say to our folks is just keep talking to them, keep talking to them. Yeah. Yeah.
Yeah. And that thinking outside the box too, right? Like, is it music? Is it a dog? How do we get this loved one from Africa, which I've had, into Canada? How do we expedite this visa? How do we expedite this plane ticket, this passport? What does that all look like?
Yeah.
Because that's important, and people will go out of their way to try and make that work.
Yeah.
Pretty
And it's
incredible.
amazing that the strength of the human spirit, I know it sounds very woo woo, but I really do believe that people will wait. They wait for somebody.
Oh, yeah.
They wait. And it doesn't have to be a person. It can be a dog. I had a woman that was, she was actively dying. And, as a nurse, you're always asked that same question. Well, how long do we have? How long do you think we have? And you can give a ballpark, but I've had people that are breathing, 4 times a minute and it goes on for days. And all you can think is, what are they waiting for? And then in that case, it was a son that came from across Canada. And when he got there, as he left, she took her last breath, and that was her. She was gone. She was waiting to say goodbye. And you can I had a woman who passed away, but she was waiting for her dog. We ended up taking her to hospice. And again, nurses, and we all think, oh, she's going to be, if this is a normal trajectory, we can predict about yay to hay, somewhere in there. Really can't give you a ballpark other than that. And then the dog came and she knew she was there, even though she couldn't verbalize it. And those are those beautiful moments of being able to be present with somebody that is in the final moments of their life, is to be able to just, holistic. It is just such a, nurturing, holistic place to be a part of.
Oh my goodness, what a privilege.
Yeah. I know as a new nurse, you came into it and you were like, someone's dying, and it was terrifying. But, as a nurse, like, if you're going for a palliative care, you want that nurse that's seen it all, because they can approach it, in that soft, gentle manner. So experience goes a long way when it comes to palliative.
Yeah, for sure. Yeah, I remember taking students through a clinical, and many of them were experiencing their first death, and they're like, what is it going to look like? I'm so nervous. Like, oh my goodness. And I was like, if it's anything but uneventful, then we've done something wrong. We want it to be uneventful and beautiful and calm and comfortable for all people involved. It's devastating, of course, but the more uneventful that we can make that dying process, the better, truthfully. And many of my students thought that was really odd that I would say that. But I think it's important to think of it that way. Like, it doesn't need to be chaotic and stressful. And I think that's where palliative care really brings that calm and that preparation into the picture for all people involved.
And it's the planning, like you say, it's the planning. And nobody can plan on when we're going to pass. But creating that conversation early so that when your family is in that position where they feel like they have to make these decisions, like, you're not capable of making a decision on your own. Where do you want to be? Do you want to continue to fight this illness? Would you prefer to, have that palliative approach where we're treating the symptoms and not the disease any longer? So,
and I think that's pretty scary too for people to acknowledge, right? Like, I know so many people that just don't even want to hear the palliative word. Like, absolutely not. I'm not giving up. But it doesn't have to be giving up. It's weighing that quality over quantity, right? And making that decision to understand, like, what is a priority for you? Is it time? And that may be, yes, you may get more time or you may not. Or is that quality, and how, like, changing the way that you are, you and your family are perceiving this process and how you're going to spend your time.
Yeah. And that's where that conversation is so hard because, people, time always feels like a more important value to consider. But, we're at a place on that journey where time really does not equal quality. Yeah. And conversations and connectedness like that, it deteriorates. And then nobody wants their last moments with their loved one being something of a trauma. So knowing that, having that early conversation and getting connected with the palliative team in your area and, investigating all the options that exist and knowing where you'd like to pass as well. So having a backup plan, it's just like any other, place in life where you need to have that backup plan. I'd like to die in my home, but if this becomes too difficult, I'd like to go to the hospice if my family is not able to continue doing what they're doing.
So for you, like, when, as a nurse, it's so challenging because often we're the first to broach the topic, right? We're the first to start that conversation with our clients or patients. So like, what are some signs that you look for in order to initiate that conversation? How do you initiate that conversation with families?
Well, I often start by asking them what they know about their medical condition. Has the doctor ever mentioned this word to you? Because you'll go in and you'll notice that there has been a lot of weight loss often comes with that sort of approaching the end of your life. You see rapid weight loss or consistent hospitalizations or, you find out that there's been a diagnosis that may have potentially a life-ending prognosis. So those conversations are sort of where I jump in. I just say, hey, so if this is the diagnosis, let's say there's a cancer diagnosis, are you pursuing treatment? And then they'll let me know, well, yeah, I've gone through XYZ and it didn't agree with me. And so I'm going to stop doing that. So that's now a decision that sometimes people make that decision, not really openly saying to their family, look, I'm done fighting this condition. I'm happy to move on, and as counterintuitive as a human being can think that, that giving up, it's moving on. These are people that are moving on from this life and it's their decision. And it's so hard to give up loving somebody and let them move on. Not that you give up loving them, but, giving them the power to make their own decision as to when they want to leave, because we all want to hold on to people that we love forever and ever. Amen. So, that's kind of where I come in is, what's the diagnosis? What are we looking at? If this is the case, has anyone talked to you about these options? And that's when I will start the process of just educating folks on, making sure that there's representation agreements and powers of attorney in place, and that they have done the extensive planning that really is required for making sure that everybody feels safe with the decisions being made, and legally, of course. I mean, not that we want to go down that road, but making sure that legally everything's covered, because you don't want to sit there in limbo while they're in a tough condition, not being able to make any decisions.
No, and it's good to have that legal stuff in place too, to better understand the thought process before this became an issue? You know, like what of, not of sound mind, but what pre-diagnosis was your thoughts on how you would like your life to end? And, you know, those sorts of things. It's always good to look back on what those ideas were and maybe revisit them. Maybe they've changed as a result of the diagnosis, but yeah, always important to kind of look back and like, okay, why did I choose this one way or the other? And why did I want, you know, all life-saving measures? Oh, because I did it when I was 18 years old. That makes total sense. And now I'm 45, right? Or 80. I don't know, right? You know, things change. So you always want to revisit those legal documents. And yeah, I mean, it's a great place to start to open that conversation amongst your family members too, because that's pretty black and white, right?
And there's the Canadian government released the My Voice book. I'm sure you've come across it. Yeah. And it is a wealth of, I mean, agonizing to read. Legalese, but there's a lot of documents in there that can be completed with really no additional expense, just witnesses, and you can get your representation agreements in there. You can get, so I don't think the enduring power of attorney is in there, but there's a lot of documents in there that can really help with that process, and not necessarily just palliative, but, you know, planning for incapacity that really does need to be made. It doesn't matter what age you are. Start planning today. Yeah.
It's true. Yeah, it's true. Tough conversations, but the more we talk about them, the easier they get, really.
Exactly.
So it's good to talk about them early. Yeah, so we talked about the signs that might lead someone to think about a palliative conversation. But all of my conversations with the palliative care team have been either, I wish that we were involved sooner because we have the ability to support this family in a way that they're not currently feeling those supports, or they're saying earlier the better. Keep us involved. You know, let's, like, as soon as there's maybe this diagnosis, or as soon as that diagnosis comes and they're open to those discussions, whether it be with social work or specifically the palliative care team, they want to be involved as early as possible. And what's your opinion behind that? Why do you think that is? And what can they bring to the table even in those early days?
I think that, I mean, again, education, I can blabber on about, you know, getting that in early. Absolutely. But connecting with the other social, like you said, connecting with the team, knowing what's out there so that you can be fully aware of where your journey is headed. So what symptoms are you potentially managing? You know, what happens if your blood pressure drops? What happens if there's maybe a bleed? What do we do? Is there a protocol in place? So, connecting with a nurse or social worker or whoever it is on that team and asking those scary questions. And then when you're in there early, I've been the nurse, I'm sure you have, in home care, where you have what we call a stable palliative. So palliative, when we're talking about it in home and community care, it's 6 months is sort of where we get that Plan P, which is it's the name of the government program that pays for medications and palliative supplies, things like briefs and soaker pads and wound care, dressing supplies, skin care, that sort of thing. So that exists. So keep that in mind. But you have access to that Plan P. Cuts down the cost. It also allows home and community care to support you with additional hours through the government. So government subsidies come in and you don't have to pay a penny towards any personal care. You have fast track access to those hospice beds when the time does come, and you get to know your case manager. So you may, if you're coming in late in the game, you know, that relationship that you really can create with your case manager or the home care nurse that's been managing wound care. They phone, they check in, hey, how's this going? And help to manage mild symptoms, things like, you know, your bowels aren't functioning as well, or they are functioning way too well. You know, managing symptoms that have cropped up that may not necessarily be a major concern for you or your family member on that day, but if extrapolated out will end up causing a hospitalization in the future. So getting in early, creating that connection, getting your education. And again, I'm so sorry I keep saying that, but, you know, creating your net. is really important, I think. And then getting to know, even going for a tour. I know it sounds weird, but going for a tour of the hospice building so that maybe you can say, oh, it would be great if we could have a room with a view, or, whatever comes up available. I'd really like to be able to come in at night so that people don't see me leaving my home, or something along those lines. Just having conversations like that, knowing that the team is there to support you through the whole process. So that's why I would say jump in early, get everything you can out of the situation as well. So you're not destitute. Your family doesn't feel the need to sell the car to pay for your medications that you may need during that process.
Yeah, in Alberta, we definitely have a palliative team, and it falls under, the home care, so the fully funded option, which is phenomenal for us in Alberta. And you access it through that same community care intake, or, your community case manager currently can connect you with that palliative care team. Many people feel like that has to come from a doctor. It's not necessary. I think once we've determined those goals of care and deemed that, we're no longer going that curative direction, and you've made those wishes very clear to your entire care team, I think anyone is privy to that palliative care team. And I recommend everyone make use of it for sure. And families too, right? The earlier that team is involved, or the earlier we start talking about palliative care and what that looks like, everyone grieves in their own time and in their own way. And that may start happening long before someone has even passed, Many times we see, loved ones who are caring for someone with dementia, and then they pass away. And it's almost like okay, like that's okay. And I have been grieving this for 14 years, and today I'm okay. Thank you for your well wishes and your condolences, but today I'm okay. And so again, it's everyone's journey is very different. And I think the more people we have on that team, the better.
Yeah. Yeah. I mean, we could go into the grieving process and how it looks so different. And that journey of a dementia diagnosis, like you said, you're grieving the whole time because you're losing little pieces. But if it's somebody that is younger, you're going to be grieving in a huge wave, and allowing people to grieve in their own way. Being in a hospice environment, you see everybody at their best and at their worst. And knowing that you have that support team as well. There's hospice support groups that meet afterwards if you have somebody that has passed away, that can help with counseling. And it's really important to not shut yourself off to the world. I know it sounds easy, because that's totally the way that I would go, is to just get into a closet and close the door. But to reach out to other people, to keep communication open with other people that have been through it or can help you through it, is really important. Yeah.
And from different perspectives too. Maybe you don't want to hear from another wife whose husband died from the same cancer diagnosis. Like maybe that's too close to home, but you do want to talk to a nurse who has seen many beautiful deaths. And that's the perspective that you want to see by pooling those resources through the palliative care team, or, through the extended care team. I think, you can get the resource that's really in tune with what you're needing.
I know that, when you're on that journey, if you're caring for somebody at home, I mean, that's where we come in with Ohana to supply that additional support, because it is a 24-hour process, because folks near the end of their life, they may not know it's day or night. They, depending again where they're at, they are going to need continuous repositioning to make sure that their body isn't breaking down in different areas on their skin. They're going to need small amounts of hydration. They're going to need consistent pain medication and management, potentially anti-nauseants. Like those sorts of medications are around the clock. And that's where a barrier can really present itself when you're at home doing in-home palliation. So having support of a nurse in the home, having support of your entire net of friends and family, if they're comfortable with being there for that process, and again, have a chat. What do you want to do? are you capable or willing, or, creating a sort of rotation where, you know what, I could do 2 hours on a Wednesday if that'll help. But knowing that you really will be suffering right along with that person, and you need to reach out, or you're going to be really, really suffering at the end of the day. It takes a village, like you've said so many times, when it comes to home and community care. We're the village. We are part of that process of making sure that it's comfort and everyone's supported, not just the person that is palliative or that is passing away. It's the whole family. We need to make sure that everyone's eating and drinking. That's what I always say. When you check in with somebody who is the caregiver, I say, did you sleep last night? And if they say no, then I say, well, what's the plan for tonight? Because you can't keep doing this. Or have you had anything to drink today other than a cold coffee that you made 6 hours ago? And if they say, well, no, I haven't, go get a drink right now while I'm on the phone with you. I need you to have something to drink. And so they'll go, and I won't get off the phone until they do. Or did you have anything to eat today? Yeah. Well, yeah, I had a burger yesterday, and I ate some cold hash browns today, and I'm good. No, you're not. You need to eat something because you are going to be suffering here. So make sure you look after yourself so you can look after your loved one as well.
Yeah, for sure. Yeah. What you brought up there was actually really interesting. The hydration, the medication to help someone who is dealing with their bowels. Despite the fact that we have said we're no longer doing curative measures, I think it's misleading to say, that it's giving up or that we're not doing anything anymore, because it's very much an active process to support someone in palliative care. We're constantly evaluating how to better support them in their symptoms, whether it be, a bowel protocol or pain management or, a terminal delirium. It's a very active and constantly revisited process that, I think that gets missed amongst many people. We don't want to create any undue suffering. It's not giving up on our end at all. It's actually creating a completely different plan. Yeah.
You go from
it's a very active process.
Yeah, you go from trying to figure it out to knowing what you're doing. Like, honestly, in a palliative diagnosis, you're like, okay, palliative hats on. I'm going to move forward with monitoring your skin and making sure that, there's no reddened areas on your body. We're going to be doing consistent, constant repositioning, hydration. You're going to make sure that their oral membranes are moistened, that they're getting oxygen if it is something that's going to help with comfort. It's not like you say, it's not like we just go, okay, good luck.
Walk away.
No. Yeah, no. If anything, it is very much more involved.
Yes, it's less poking and prodding.
100%,
yeah. But it's still very involved. I mean, some of our palliative clients where you're doing hourly pain medication are some of the most involved clients. Whereas someone who's not in that palliative trajectory is maybe a little every 4 hours I'm doing vitals or whatever that looks like, right?
Yeah.
So I think that's something that is so key for people to understand is like, we aren't stopping anything. We're going to nitpick the vitamins and the big pills that you don't want to take anymore and
immediately out the door. Yeah,
absolutely.
Omega, no.
Calcium. Yeah, let's get it out of there. Yeah, but for us, it's very much an involved and active process. And I mean, I think, like you said, you just put the hat on and you know exactly what you're going to do, and you know what's available to you, which is wonderful as well, which is almost endless.
Oh, it is. I know. That's why I love palliative doctors so much. They come in and they're like, what do you need, sister? And you're like, I need all of this. And then maybe all of that too. So I love the palliative team. Like you say, it's stunning the way that it works. And it's so compassion based. Yes. I love it. And then when we're there, let's say, you're in the home, you're providing that sort of more medical side of the support, managing the symptoms, et cetera. And then you move into a place where the client's family are no longer in that role. And that's lovely because they get to breathe. And you can say, you know what? I'm here. Go take a step back. It's okay. I've got it from here. If you need to nap, go have a rest because this is not, often it can be weeks in a row where you're in this 24-hour care model where it's always somebody's up doing something or eating, or, family gets up at 3 a.m. because they couldn't sleep and they pop in to check on their loved one. And there's somebody at their bedside that's making sure that they are hydrated, that they are, they have everything, that they're comfortable, and that, they have what they need. So supporting the family to have that quality time where they can walk away and they can all, you'll walk out of the space where you're looking after their loved one, and there'll be a room full of people and they're all looking rough. Oh man. We're not that I'm anything to look at, but they're hungry and they're tired, but they're together. And you have people that can very much be leaning on each other. And again, family dynamics come into it. So that doesn't disappear because we're palliating, but being able to take that nursing component off of their plate and the personal care component off of their plate so they can go back to being a loved one with that quality time that they can spend together talking to their loved one and giving them privacy so they can have those moments when you're no longer needed in that space.
And the peace of mind that someone is there to say, okay, like now's maybe a good time for us to come together. Let's, sit at the bedside. I'm going to give you this space. Because, people think they're going to miss out, right? They're going to wake up from that nap and mom or dad is going to be gone. And that sense of loss or that regret, that doesn't sit well. So having someone at the bedside that's professional, that can say like, okay, things are moving in a quicker direction now. And so now is a good time. And that, tap on the shoulder, like, do you want to get up and maybe sit with mom for a few minutes? And, we're not going to go and be like, you got 5 minutes, let's go kind of thing. It's that progressive, like, I think maybe it's a good time for us to call your daughter and ask her if she'd like to come over. And it means everyone doesn't have to be there and everyone can take that rest in that space that they need to.
Yeah. I can say when a nurse phones you to say you should really come and visit, you should really come and visit. You really should. Yeah. I've had families that think it's a request. You need to come if you want to. If you're somebody that wants to be involved at the end of this person's life, then you need to be there when we call. I know that sounds really selfish, but I hate to have somebody pass when their loved one's not there if that's not what they wanted.
Yes, agreed.
Yeah, and again, I mean the human spirit. Again, preachy, but people can choose when they go. So you can have someone that goes, oh, you know what? I just went in and I saw mom and she's doing so well. And then they're gone. And that was mom. Mom was like, I'm going to trick you. You're going to think that I'm going to be here forever. Or I smiled. I had a sip of water. We had a great conversation. And then you left and so did I. And that was it. People really do decide. So I think carrying that grief with you that you weren't able to be there, mom would have hung on for years if you had stayed. She wanted you to leave so she could leave too. She didn't. Often people don't, when they make that decision to pass, they don't want you to be there if they've chosen that. They don't want you to witness them leaving, or they want you to be like, there's so many instances in my career where I've been able to, and I'm sure you have as well, where you can see that this person has made the decision that as soon as you leave, I'm going to go, or you reposition this person and they're comfortable and they've seen everybody. And then it's this peaceful moment where they'd go, okay, well, I'm good now. Everything is just fine. Thank you. Yeah.
And it's okay to say, I don't want to be there. Wake me after the fact. And that's totally okay. Like, I think the permission to be yourself and to recognize your own limitations and, to not be prepared to see that last breath is totally okay. I think it's just that conversation. And never will a nurse or a palliative care team member say, no, absolutely not. I think you should do this.
You need to stay here.
Yeah. No one is ever going to say that. I think in having the conversation, many people are asking permission of themselves to be okay with that decision. And they're just kind of throwing it off of you to just verbalize it so that someone can appreciate and, be okay with it. Like, yes, absolutely. If you don't want to be there, I'm not going to wake you. Yeah. And when mom is clean and she, is ready to go and we can start talking about calling the funeral home, then I'll bring you in. Absolutely. And you can have that moment with your mom or your dad or whoever that may be, right? But yeah, oh my goodness, everyone deals with it differently, and you're totally okay to deal with it in your own way.
Yeah. I like to think that if somebody is leaving for the last time, they leave the party. It doesn't necessarily mean that they didn't love you.
Yes.
They know how you feel about them, and you know how you feel about them as well. Just because you didn't get to say it one last time does not make it any more or less real, those feelings. So really the upshot is, if you didn't get there on time and you didn't see your loved one and you really wanted to, they knew,
Mm-hmm.
they knew how you felt, and they know. So,
yeah. And it's okay. It's all okay.
Yeah.
Yep. Yeah. And it's okay if you're a sobbing mess when we do call you. And it's okay if you're completely stoic and have no idea how to react. It's all okay.
Yeah. It looks different for everybody.
Yeah, totally.
Yeah.
So how does Ohana, let's say, tailor their approach to palliative care?
I mean, we've talked about the approach being so different for everybody, of course. But yeah, supplying the type of care that is needed is really important. So for Ohana, we have registered nurses, LPNs. So if we're looking at, round the clock medication administration, that's where we would go. If we're looking at providing supportive care for personal care, hydration, assistance with meals, we have HCAs that we can bring on for those kinds of roles. And a lot of other companies as well, they have that same system where you can have a nurse or a healthcare aide to assist with that. But really the difference lies in the individual themselves. So reaching out to the palliative care team, we will always do that. We want to connect with the people that are able to give us advice, medication, prescriptions, and then connection to that hospice bed if needed. So I always like to reach out once I have a client under me that is classed as palliative. I reach out to the palliative care team and just let them know that, hey, I'm here, I exist. So if there's any concerns, palliative care it's a 24-hour job. It really is. But there can be times when you can't reach the team member that you really need. And reaching out to Ohana Care and connecting the two of us with who your individual is that is helping to facilitate the process with the health authority, and then us on the other end, and being a team. So connecting the team, creating our staff member team, and talking with the family. And it really is, it's all about communication when it comes to the end of the day, is making sure you're connecting the dots.
Yeah. And again, that may be a physician that we can loop in, and, in home care, that's totally a possibility where we can liaise with the palliative physicians on the palliative care team. A lot of times, this is Alberta experience, they won't support, the funded palliative won't support overnight care. And so it may very much, a private team like Ohana may join your care team for those overnight visits. But the rest of it is covered by funded supports. But
yeah, which is bonkers, because really the overnight is where people fall apart.
Yeah.
You can do the things during the day, but if you don't get a good night's sleep, there's no chance that you're going to continue to fight that fight. Yeah. And then companionship, just knowing somebody is there. And then you can actually sleep. If your loved one, they have what they need, they're in the other room, you can get a good quality sleep because you know that they're being cared for effectively with one of our caregivers.
Yeah. And our caregivers have the experience. Excuse me, my goodness.
Yeah.
Our caregivers have the experience too, right? Yes. So our healthcare aides are also trained in palliative care and have the support of you and I, and the rest of our administrative team and our nursing team, to support them if there are questions or concerns or needing virtual support or needing a medication change, things like that. We're totally available to support that as well, which I think is an asset that we have at Ohana Care, to have that much experience to back us and the 24-hour support. But also such a privilege to be a part of that. I love to be a part of that. Yeah.
Well, I think I've been your ear enough, lady.
Oh, I love listening to
Yeah.
you talk, Liz. I really do. Uh,
You poor thing, hey?
yeah.
You're a sick
I mean,
woman.
this is a big topic. This is a heavy topic for sure. I think we could talk for days about our experiences and um, all the different options available to people. But, I think as we say in every episode, the resources are there. You just gotta say one word, some word. We've probably heard most of them and can understand what you're asking without you really asking, um,
Yeah,
and
kind of like
provide you with
guide
the
the
support.
conversation along where it needs to go. Did you think about this? Yeah. Yeah,
Yeah.
and access to support in the home as far as like occupational therapy and transfers and toileting and all of those things that alter as that progresses. We have been there, we have done that, we know, I mean, we've got the t-shirt. But we can access it even if it's not in with Ohana Care and it's not, anything that's directly related to myself. I would rather help you. You phone, we can help you. We can get you connected, even if it's not in my local community. We do have connections outside of that. So, yeah, just say the word. Say the
Yeah.
word. Yeah, we're
And
all way too eager.
yeah, for sure. And we pool resources too. I mean, Liz and I are constantly banging ideas off of each other. Banging ideas? Throwing
Let's go with
ideas
that.
off
Yeah,
of each
I don't
other?
know. That
I'm
sounds a
not
bit
sure.
hello. Yeah.
Stay there. Yeah. We're always talking about ideas and, trying to seek support from each other when it comes to different clients. And our team, our admin team is a phenomenal team as well, that has just a plethora of experiences that they can bring to the table. And it really doesn't matter what their background is. They've all been in healthcare long enough that they've seen a lot, and my goodness, we share just about everything with them. So they're jaded as well.
Yeah. Just enough. Just enough. Yeah.
Yeah. So it doesn't really matter who picks up the phone. We pool our resources too and would love to support you. And it's not going to be, just hold on or we'll give you a call back. Like they're going to sit and talk to you and hear what you have to say. So that you're not having to rehash it over and over and over again too. And that continuity of care, I think, is really valuable as well.
Absolutely. Yeah. Yeah.
Yeah. All right. Well, Liz, thank you again for this
Thank
chat.
you. Thank
I
you for
really looked
listening.
forward to it.
If you made it through this
thank you.
far, please like and subscribe. And if you have any requests for where you want us to take the next episode, topics that you want us to cover, even just little specific things, please, you can make a comment below or you can reach out to us anywhere you can find Ohana Care in Canada. It's us.
Yeah, for sure. Thank you again, everybody. Play safe, and we look forward to seeing you guys next week.
Bye, everybody.
Bye-bye.